So welcome to this next webinar. Today we're going to be looking at the issue of triage, and we're going to look at it in the context of ethical issues and some of the management challenges. I'm delighted to be taking part. My name is Dr. Leng. I'm an internal medicine physician and palliative care specialist, and I've had the privilege of working in this area for around 30 years, and many of those years in India, but also in other parts of the world. I join you today from Kampala. We're going today to be looking at the background for ethical decision making. I think some of you can remember your ethics from your training, so please think of what those principles are, because we're going to talk about them a little briefly. Then the more tricky issues, how to balance those in the clinical setting, particularly of COVID-19. We're going to introduce you to our triage and goals of care algorithms, and then come back to what our values are as healthcare workers as we approach this issue. Please, if you haven't done it, record right now. Download right now this ebook. All of these webinars are to act as a resource for this ebook. In fact, together we're calling them the Resource Toolkit for Palliative Care in Low and Middle Income Settings in COVID-19. We've also given a lot of references at the end, and I mentioned one more at the beginning here. This app has been developed in Bangalore. It's very good for general symptom control. It's very good for general symptom control for adults. So please use this resource. I hope you've downloaded the ebook, and then we'll continue. So, setting the scene for ethical decision making. These are ways in which we have a framework or principles that help us. They're there throughout clinical care, but they become particularly relevant when there are end-of-life care discussions or decisions. They should not be culturally dependent, but of course they will have context and cultural implications, and I'll mention some of those as we go. They are not legal frameworks, and ideally our legal frameworks in our countries reflect the appropriate ethical principles. Sometimes that's not always the case. So when we look to apply them, we have to do some balancing. What is the benefits and burdens of any intervention? And what are the benefits and burdens of any intervention? What is the legal framework, and are there any problems with that? In particular, what are the wishes and what is in the best interest of that patient, but also in our wider society? And finding that balance can be tricky and can feel like an impossible task. So did you remember the 4 principles? Just to briefly remind us, autonomy, the ability for a person to make their own choices. Of course, to do that, you need effective communication, you need truth-telling, you need honesty, and you need some trust. The family need to be involved in that, particularly in collective societies, but the patient should be able to make their own decisions if they would like to. Then beneficence and non-maleficence, benefit versus harm. Are we going to improve this patient's situation and their future outcomes, or are we simply starting something because it's a kind of process or procedure that we haven't reflected on? And in particular, in the era of COVID-19, are we doing something like invasive ventilation with no prospect of good outcome, in which case that would come under this particular ethical principle? And lastly, and perhaps very challenging, how do we balance resources? Collective societies are the norm in low and middle income settings, where we don't make decisions simply as individuals, but we make them in the context of our society and our community. I mentioned this South African term, you might know it, Ubuntu. It's talking about I am because of what we all are. That sense that we are part of our communities, and our communities are part of us. Desmond Tutu, famous for his work in the Truth and Reconciliation Committee, talks about his humanity being inextricably bound up in ours, that sense of common humanity. And I was delighted to visit Kuki people in Manipur and see a very similar and fascinating social cohesion system, again called Kanko this time. So justice. How are we going to ensure a fair use of resources while paying respect to these ethical principles? This has caused a lot of discussion. People have been counting ventilators, wondering whether or not we're going to have to start putting in a cutoff for who would be considered for a ventilator. And that's causing a lot of dilemma for the healthcare workers and a lot of fear for people in the community, particularly people who are particularly vulnerable to COVID-19. I would just encourage us that, we do these decisions day in, day out as part of healthcare, particularly in resource-limited settings. We are continually having to discuss with the family their personal resources and what their personal wishes are, balancing that with the clinical scenario and with what's available in our setting. So I would encourage you to not panic because it's COVID-19, but to use those skills that you already use daily, but to think them through in this particular setting. And to try and think them through in advance, because once the situation is hectic and the patient is very sick, it can be difficult. And I want us to remember one more principle. Physicians are not ethically obliged to deliver care that does not have a chance of benefiting. We talked about that principle. But this is actually a professional judgment, a consensus judgment. Don't make it as an individual, do it as consensus. But there are times when it is not actually in the best interest of someone to do an invasive treatment or to continue an invasive treatment. And that's where we begin to think of some of these invasive treatments, such as ventilation, in the context of COVID-19 for those with comorbidities who are unlikely to benefit. Let me take you on a little journey with a doctor who wrote in the New York Times. It was a very interesting title. She said, all doctors are palliative care doctors now. And I'm, as a specialist, very happy with that. The whole point of these webinars is to empower others to get our skills and competencies up to scratch so that we can support our patients and families and each other. But what she's talking about here is that she's found herself struggling to do that presence, being alongside, supporting and ministering to the distress of people, dealing with existential questions, aligning the patient's values and priorities with her own, and very importantly, individualizing all of those, because we're not dealing with a statistic, we're dealing with a person. And the lovely thing is she's remembering that this is the heart of medicine. And in palliative care, this is the heart of what we try and do as holistic care providers, is to say there's always much more to be done. That actually numbers and excellent research and fabulous clinical skills are vital. Our patients deserve that from us, but they also deserve that given in a compassionate, holistic way where we sometimes bear witness to suffering and we accompany people on that journey. And we challenge in ourselves this need to want to always save. Sometimes our job is to work very hard to improve the quality of living, the quality of dying, but to work alongside. And this last bit, our patients need to feel seen, non-abandonment, the fear of dying alone. These are really, really important issues in this current pandemic. So what about the legal frameworks, where there's a lot here and it may be different in the countries you're coming from, the settings you're coming from. But please have a look at some of these very excellent papers in the Critical Care Journal in India. And there's also a brand new one, which is written particularly looking at some of the issues for COVID-19 and palliative care within an ICU setting. We have new legal frameworks in India. Other parts of the world have different legal frameworks. Be aware of them. And many of them do contain guidelines and consensus statement for professionals. What intrigued me that a couple of these consensus statements, which were very helpful, written a few years ago, also included some philosophical statements, which I shall come on to. I also thank colleagues who are working to interpret the current changes in the Supreme Court legislation in India to produce guidelines that are going to be very useful for us going forward. Particularly, I mention here Manipal Hospital and AIIMS in Delhi. So we have a maze. How are we going to find our way through? We've looked at the principles, we've thought of the challenges, we've thought of the importance of the values we bring to this. Here's those philosophical statements that I was mentioning. Death is not extinguishing the light. It is putting out the lamp because the dawn has come. I love seeing a quote like this in an academic journal. It's just reminding us that sometimes we're accompanying people on that final journey, which will happen to us all. But the dignity of that and the fact that people are not abandoned and that we are not medicalizing that event unnecessarily is really important to remember. Now we come to the particularities of COVID-19. We've got very vulnerable patients and families. There's a sense of anxiety and desperation. There is a big fear that people are not going to get the help they need. There is huge inequalities in access, even within the same areas. Holistic issues are often ignored. Most of the task force recommendations from across the world for COVID-19 are not prioritizing holistic issues. And then I'm hearing a lot of pejorative language. We're talking about victims. We're talking about suspects. These are difficult words that just increase the stigma. We're hearing about medical staff who couldn't even be buried in their after dying of COVID-19, having cared for patients themselves. We're hearing about people who are not allowed back to their homes. This is a difficult time, and we need to work with our communities to try and deal with some of these issues. We must do our COVID-19 response within a planning process. This is the WHO strategic planning process. Those plans should include the disease management options, the communication, how we're going to test, how we're going to use the different levels of the health system, how we're going to give feedback on where resources are available, and how we're going to offer holistic support to the patient and the family. And perhaps most often left out, how we're going to support one another and support compassionate care, but in a caring way to each other. I show you an example of Kerala's prepared strategy, and we go through this in the ebook. And this shows how our algorithms and our guidelines are directly linking in to the different levels of intervention that have been offered in Kerala. And of course, this will vary in the settings you're in. You may even wish to replicate this for your own setting. So we're going to come on to triage and goals of care. And there are other webinars looking at communication and psychosocial issues. But let me just remind you of one of the tools we can use. Effective communication is vital. It's, if anything, the most vital component of all of this. The clinical decision-making may be a little straightforward, but if we have got this, the clinical decision-making may be a little straightforward if we have got this effective communication right. The Spikes tool is simply giving us a protocol, a framework. How do we set up the interview? Now, in this setting, we may not be able to go into separate rooms. It's very unlikely. But we can create that kind of space by our body language, by the way we use our voice, by the way we use the visual cues that are there. Even a light touch with a gloved hand may make a big difference to setting that scene, to showing that for those moments, we are focusing on that person, that we are wanting to know what they already know. We want to explore what they want to know and whether they would like a proxy or a family member to know the information, whether they would like to know themselves. And only then do we start giving information. Of course, many people start giving information right at the beginning, and don't forget these first crucial steps. As we're giving information, we are assessing the response, we're using our empathetic, particularly verbal statements. With PPE, we have to rely much more on verbal statements than perhaps we did before. And of course, we summarize and agree that the way forward. This is a very moving picture. And this quote is from Zimbabwe, where the first person who died of COVID-19 was in ICU without any ventilatory support and because of issues of resources, and was sending out a text and saying how scared and how alone he felt. Please let us not have people dying alone and scared. In other webinars, we're going to hear more about symptom control and other ways we can help. But there's ways to be present while still keeping the safe PPE and a safe distance. Do remember, as I say, those verbal skills. Remember dignity. Show empathy. A colleague said, if you are speaking from the heart, that will be heard. And I think that's a very important thing to remember. And work as a team. It may not be you that does the whole communication. Perhaps you start off the communication. Perhaps other team members take over from you. Perhaps you refer on to other teams such as psychosocial support teams, palliative care teams that can give additional support so that this communication is a process. Here's our goals of care algorithm. It goes across 2 pages and you may find it tricky to see on the screen, so please download and look at this in more detail. But this is taking us through people who have been confirmed to have COVID-19. And we're beginning to look at 2 groups here, one in which we expect good outcomes, and we're going to then refer for active invasive management if appropriate. This is the referral point before ICU that we're talking about. Then, of course, our critical care colleagues will take that one step further. And nowadays, there are a number of other interventions, such as non-invasive ventilation, high flow oxygen that may be appropriate. But we're also beginning to think of those with significant comorbidities, who are older, whose pre-morbid, pre-COVID functional status was very poor, who may have a very limited life expectancy because of some underlying condition. We're having these conversations in a safe way. We're using those skills we talked about, and we're finding out how much the person wants to know and who else they would like to be involved in those decisions. We're reassuring if we can, but we're not falsely reassuring. And we're making sure that we use our empathy, we make consensus decisions, we document, and then we discuss the way forward. And please remember, there is always something we can do. There is a huge amount we can do if we recognize that someone is rapidly deteriorating and now in an end-of-life care scenario. And again, I remind you that other webinars will cover this, and it's fully covered in the ebook. Page 2 gives some of those reminders, examples of empathetic statements, other tools you can use. Please review that and review that in the communication skills. But just one word of empathy. This must be a very distressing time. We will not leave you alone. Those things can make a huge difference. So then our ethical algorithm, this is just a framework in order to put together all of those things we mentioned. So you see on the top, patients who are triaged straight through for continuing active management according to the protocols in place. And then the rest of the document is really trying to help us support those patients and families for whom invasive ventilation is not likely to benefit. We talk about it, we do refer on those who possibly might, we discuss as a team, we make a consensus together as a team. Ideally, you have some support for that by a triage supervisor, maybe on the clinical floor, perhaps behind in an ethical committee. At every stage, you offer excellent psychosocial and spiritual support. Families who feel that we are on the same side as them. We're not fighting them. We're not saying we know better than them. We're not trying to take away something that should help their patient. We're trying to make the best decision together. We need to make sure we sound and we act and we mean to be on the same side, to be working together for the very best we can for this person in front of us. Once you have come to a consensus, communicate that and document that. And if there is any conflict or decision making, that's when your supervision can be very useful. Of course, this can be flexible. People may move from a potential treatment line to actually very clearly now deteriorating. And remember, excellent symptom control, particularly if we're moving into an end-of-life care scenario. And the notes at the end of this document also just remind us of the things that we've said already: communication, documentation, remembering the issue of futility, referring for further management. And again, a reminder of the other algorithms and ebook references. How do we do that assessment? Different scores are used. We debated whether to use some of the scores from other settings, and I'll show you some of those in a moment. But we decided to recommend the WHO Performance Scale because we're anticipating that these algorithms will be used in a number of settings, including primary care and community settings. And this is well known and relatively straightforward to use. And as you see, 3 and 4 represent people who've got significant functional problems, and particularly level 4, people who are unlikely to benefit from invasive management if this is their normal scenario. Here's one used elsewhere, developed in Canada and used in the UK, called the Clinical Frailty Score, which again is using a functional status with number 9, including those with a life-limiting illness of less than 6 months prognosis. Many ICU colleagues are using an organ failure score to really determine outcomes. So it's not so much a triage tool, but it's for our critical care colleagues as they're looking at whether or not to ventilate a patient. I really like these principles. They were written for a previous H1N1 flu pandemic and then adjusted. They're UK guidelines, but they're reminding us when we're making these decisions, be accountable, remember that ethical background, be inclusive. Inclusive both in terms of the patient and family, but also in terms of your colleagues. Be transparent, and that's where the documentation is important. Be reasonable. Let's weigh up the evidence. The evidence may change. There may be new papers come out and that changes the prognosis. So be reasonable and be flexible, and make sure that you're making those principles clear as you communicate. There's a series of excellent briefing notes. I highly recommend them to you, being produced by a number of the global palliative care organizations. And when I read this, I was struck by the very first principle. Can you see it? Non-abandonment. And that comes right back to what we were talking about. The person needs to know that, and the family need to know that we're not going to abandon their relative. I have a neighbor whose mother died sadly recently, 1 continent away. And she remembers very powerfully one last WhatsApp call facilitated by a doctor in full PPE that allowed 1 sentence to be exchanged. And that's made a huge difference for her. And the other was a short message sent by the treating nurse saying how those last moments had gone. I read a beautiful story from the UK recently where 2 hearts are made, one with the patient, one with the caring family who are so concerned for their loved one. And again, the nurse allowing communication about what was happening in that ICU setting. This will be the same if it's an isolation setting without ventilation. It also remembers reciprocity. So when we're looking at the issue of justice, please also remember our colleagues. We should not put ourselves in undue harm if we're going to care for the next patient and the next patient and the next patient. Let us really seek to make sure that we're working in a safe environment to protect our patients and to protect each other. So just as we near the end of this webinar, we want to preserve that continuum of care. We need to think particularly of people who have pre-existing comorbidities. If you are looking after people with chronic disease, have these discussions early. Sometimes we call those anticipatory care planning. Talk about it early so that we're not having to discuss it in a difficult situation where oxygen levels are dropping and agitation is starting. Use those ethical frameworks. You can communicate. You've been doing it all of your career. Pick up some tips. Think about it. Maybe get some help from colleagues, but use those effective communication tools, even if it's in those small moments in a hectic schedule that you can. Document. Make sure you have backup and supervision, The palliative care teams are there ready to help and support you. And know what your situation is in terms of your institution or your legal backups. And remember holistic care. And lastly, remember those issues. It's so easy to discriminate. It's so easy to somehow be so busy with the medicine that we don't make sure someone is accompanied on that very important last journey. And so I just finished with some other reflections. This is a New York doctor talking to an Italian doctor. And they're both overwhelmed. They're both struggling to know what to do. They're used to acute care. And the Italian doctor is beginning to say, I'm struggling to stay human. I think I need to separate myself off in order to deal with this. The US doctor is saying, I'm used to doing everything for my patients. It's an interesting phrase, pushing mortality to the edge. I have never felt less useful. That sense of failure, which is so common if our normal way of working is saving lives only. Saving lives is great. But in many parts of medicine, we have to adjust to actually a more chronic disease management, a more holistic management, and sometimes an end-of-life care management. I see this kind of response in young doctors coming into palliative care for the first time. And yet when you make that adjustment, and I made it myself 30 years ago, it's incredibly important because what you find is that sense of common humanity. I love this last comment, staying human is painful, but it's what I need to keep on working. Many of you will know our friend Khan in this picture, and I've been very struck by some of the things he said, knowing that he was facing a life-limiting illness and knowing that that was coming to an end, his life was coming to an end. And he talked about the importance and the challenge and the difficulty of saying goodbye, that moment to say goodbye, and yet how important that is for the people that are left behind. Humanity to infinity sounds a bit like a superhero call, but this was what was said by a student I was teaching in a medical school in Gaza when I asked him what palliative care meant for him as an undergraduate. And I've been thinking about this a lot since. What does it mean to show humanity until infinity in our global sense now? I like to think not just about social distancing, that's a difficult term, physical distancing for sure. But there's a way in which we are seeing social togetherness. We're seeing acts of compassion in many and innovative and creative ways. And we are seeing a global solidarity. Let's get behind that. Let's support each other. Let's put our patients and families at the center of our care. Let's use our ethical decision-making, our excellent clinical skills, our communication skills, and let's take care of one another. I wish you well as you go forward with managing patients during this time. I also just want to outline a number of resources that you can look at in more detail. They are including resources from other settings for low and middle income, and also critical articles and guidelines. Thank you to all who contributed to this series. And also, we really would like you to fill in this Google document, if at all possible, to give us feedback about how these webinars have been used, where they've been used from, and ways in which we can update our resources, because we see these very much as a living document. Many thanks.